Despite our best medical care, there are times when treatment is no longer helpful. Then, how do we help people at the end of their life? Care to reduce suffering tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Suffering may come in many guises: physical pain, mental distress, stress about what's going to happen next. There's no one pill to help relieve suffering, but rather a menu of options that aim to improve the situation as it develops. First, let's take a look at this week's Prairie Doc quiz question. It's a true and false question. Placement of a feeding tube improves survival by reducing the risk of aspiration or food going into the airway. True or false? We'll give you the answer at the end of the show. Well, joining us tonight is Dr. Francine Arneson with Avera Medical Group Palliative Medicine in Sioux Falls, and Mary Hill, a nurse with a law degree that serves as Vice President of Ethics with Avera Health. Thank you both for being here. So, Franny, tell us, you're a neurologist to start with. Where did you train?
At Vanderbilt University in Nashville, Tennessee.
And then, are you from here originally?
North Dakota.
You're a North
So
Dakota.
our friendly neighbor.
Yes, a friendly neighbor, yes. And so what brought you here?
Well, my husband and I both practice medicine, and after we completed our training, we were looking to get closer to home, be near family.
Yes.
And Avera Medical Group seemed to be the best fit for both of us. And we've been very happy here.
He's from where originally?
North Dakota as well.
Oh. There's a good balance to here down in the southern Dakota.
A little warmer.
A little warmer, although kind of cold today.
Right.
Mary, tell us a little bit about yourself. Where did you train?
I received my Bachelor of Nursing at the University of Cincinnati. I'm from Ohio originally, so I'm from the southern Midwest.
Yes.
And I'm learning that the northern Midwest is much, much colder in the winter. Yeah. Who knew? And then I worked as a psych nurse for a number of years, and because the population I worked with was severely and pervasively mentally ill, we interfaced a lot with the court system because many of our patients were on court commitments for mental health treatment. And that's what got me interested in pursuing a law degree.
And where did you get that?
At the Indiana University School of Law in Indianapolis.
So here you're from Cincinnati and Indianapolis and all that, and what brought you out here then?
Well, my husband and I actually moved around to various states with job opportunities, and it wasn't until I came to South Dakota that I realized that this is the 5th state driver's license I've had, and that's a lot of moving. But actually, it was the job at Avera. I saw the job posted on the Catholic Health Association website, and it looked like my resume was put right into that job ad, and I knew it was my calling.
And you said, I'd like you to hire me, and they said, ooh, yes, done.
That was almost the story, exactly. In fact, it was 2 years ago in November that I came to interview. We were living in Tucson, Arizona at the time.
Oh, yeah?
So it was a little chillier when we got up here. We left in January, it was 78 in Tucson, and 3 days later when we arrived, it was negative 11.
Yeah.
So that was quite a shock.
Yeah. So my wife is from Jacksonville, Florida, and we moved from Jacksonville, moved our stuff up here, and I think when we moved, everything that had been stored in my parents' garage to our new house, it was like a chill factor of 69 below. The coldest day of the century, they called it.
Wow.
And thank you, South Dakota, for making my Floridian wife feel right at home. So tonight's topic is about suffering, really, isn't it? It's about end of life. It's about palliative care and hospice care, and people really don't understand a lot about some of these things, and I think this is probably, I'm going to say this right to you people, this is going to be one of the most important shows that we've done. And if this is a time when you have family home, make sure you record it anyway and let them all hear this, because we're going to hit on some important things that we need to think about. And let's just jump right into hospice versus palliative. What is the difference between palliative care and hospice care, Franny?
That's a great question, and there's a lot of similarities and a lot of differences. Palliative medicine it's a medical subspecialty made up of different interdisciplinary team members, so doctors, nurses, social workers, chaplains. That's similar to a hospice team.
Very similar.
Right. The biggest differences lie in when you can have the service. So with hospice care, Medicare kind of arbitrarily put together a timeline. So you have to have a physician that feels like you're looking at 6 months or less. Right, to qualify for that Medicare benefit.
And I would add, I have placed a bunch of people into hospice in my career. I am the hospice medical director for hospice in our community in Brookings. Kick them out when they get better. I mean, they don't. It isn't an absolute. If you qualify for this added Medicare benefit, why don't we just start it? Doesn't mean you're going to die. Of course, we're all going to die.
Right.
But I interrupted you.
No, please. I welcome conversation.
Okay.
So with palliative medicine, however, it can be care that's delivered at any point along a serious illness. And the aims tend to be very similar, though. You know, working towards symptom management, not just physical symptoms, but emotional, psychological, spiritual, social concerns, and making sure that we're addressing whole person needs. We also spend a lot of time in palliative medicine talking about what are the medical options, what does the family understand, what does the patient understand, and what are their biggest priorities? What do those options look like in their life in particular? And so we help them navigate the medical system and advocate alongside them for the kind of care that they prefer.
Right. Now, I'm thinking about palliative care and hospice care being a movement that's taken up a fair amount of energy because, and this is what I think is why I'm going to throw at you, because there's this huge need. We have been inadequate in what we've been doing in modern medicine. And I'm saying that to you. Do you disagree or agree? And how do you think palliative and hospice care has been able to address that?
I think palliative and hospice care has reintroduced us to the care factor of medicine. In the United States,
reintroduced us
to the care factor of medicine, because in the United States we have so much technology available to us, and we equate more technology, more medications, more interventions with longer life, better quality of life. However, studies show that often persons with terminal illness actually live longer, have a higher quality of life, and a better functional level when they're receiving palliative medicine and hospice care. So it's somewhat counterintuitive to our American psyche, where we think technology is always good and always advancing our goals.
And it doesn't always do that, does it?
Not necessarily.
So the support study was this huge study, and then they repeated themselves back in 1998. It talked about how people receive care in teaching hospitals throughout the country, something like 7 or 8 different hospitals. Could you explain what happened in that study, or am I putting you on the spot?
I would defer
Turn
to
to
Franny.
You want me to summarize
summarize and we can discuss.
So they had they looked at whether patients had advance directives or not. They looked at whether, if they had an advance directive, did the attending house staff, most of it is teaching hospitals, so it's house staff, respect that? And then they looked at how good were we at really knowing prognosis. And pretty darn sure we knew there was a 0 prognosis of survival. Then how did the house staff react to those people differently? And the answer, and then how much pain were these people in at the end of their lives? And they did this big study, all these different hospitals. The answer was the people who came in with advance directives, they didn't respect those advance directives for the most part. And they didn't push to try to get an advance directive when it was appropriate. And then when they had a prognosis of 0, they still did every resuscitation and all of the whole 9 yards that they could do. And then when they looked at the pain level of these people, they found that 50% of the time these people were suffering and in a great deal of pain greater than, how did it go? I mean, I'm throwing this off the top of my head, but 50% of the time had severe pain. And so they said, okay, we need to do better. And so they had a teaching team that would teach the doctors and teach them about prognosis and respecting the choices and so on and so forth. And then they repeated the study, and there was no difference. No difference. And so prognosis, so palliative care and hospice care really kind of came to the answer, just as you described it.
Now, were surrogate decision makers involved in those cases? When you talk about advance directives, was that a living will, or what was actually being looked at as far as the advance directive?
I do not remember. Surrogate meaning the family helping make decisions.
Yes, or healthcare power of attorney.
Right.
Absolutely.
Right, and the answer was, I think it was early on, the whole idea of an advance directive, and I can't think of a more important lesson from that support study about the value of advance directive and making sure your family, the surrogates,
Yes.
know what your wishes are.
Absolutely, because advance directives are pieces of paper or chart documentation that has words expressing your wishes. Words are symbols. They have to be interpreted. And so there's no way you can know today all of the eventualities you might face in your healthcare journey, in your life journey. And so it's very important, it's imperative that you have the conversation with your family. Not about necessarily specific interventions, because again, you don't know what your diagnoses might be, your comorbidities, but talk about what's important to you. What do you value? Your family hopefully knows who you are. What kind of a life has meaning for you? What would be a quality existence for you? What are things that you really don't foresee yourself wanting to live through? And this show is being broadcast right around the holidays. And if you haven't gotten your mom or dad a gift, or your children, this is a wonderful, wonderful gift to give them.
An advance directive.
An advance directive and the conversation. Because what it does is it takes the burden off of your loved ones for having to make horrific decisions, often decisions where there are no good options, and they're trying to choose between options which are all bad. And then having to live with the consequences and feeling like maybe they gave up or should have insisted on something different. So the gift of having that conversation and taking the burden off your family members could be a beautiful holiday gift this season.
Right. You want to? My comment is that if you say you answered 3 questions and you told your family, you know, and I don't want to diss any lawyers. Lawyers do wonderful things, and putting it on paper is very important.
Yes.
But the conversation is so important. So if you could answer these 3 questions, here they are. Number 1, if I had a cardiac arrest right here and now, I'm 85. The best way to die probably would be a sudden cardiac event, you know, either no dementia, no all that. Would you want me to do CPR, yes or no? The second one is, if I become demented and I don't know what's going on, and I don't recognize my family, it's permanent, would you want CPR, yes or no? And the third question, and this is the big one,
Yes.
would you want the feeding tube?
Yes.
And my answer on those is, well, yeah, right now I'd have you do CPR. If I didn't know what my family was and I had very poor chance, forget about it. And the last one, feeding tube, you know, if you think there's a reasonable chance that I can recover and come home and be active, and okay, that's generally not the answer.
Yes.
Franny, now I threw that at you. Would you disagree or change?
No, I agree with you. I really like approaching advanced care planning more in terms of qualities of life, goals, as opposed to specific interventions. So, you know, if you were to have a disease process that your thinking was not going to be clear, that you weren't going to recognize your family and loved ones, is that a good enough quality of life for you? And if so, we should do a lot of medical things to try to sustain that.
Yes.
If it isn't, then we should focus on
Comfort.
or other options. Same with physical disability. You know, what degree of physical disability would you find acceptable as a quality of life? And, you know, defining those things for your family truly is a gift. I agree with that.
Okay.
There's a physician who's well known in the healthcare community, and he says, I have an advance directive, and I've had the conversation, not because I have a terminal illness, but because I have a family. And I think that that is really the bottom line. We do this
Yeah. Wow.
as a
that's
gift
a powerful
for our
point.
families.
So they're unburdened. They don't have to go, oh, you know, a
Yes.
feeding tube, and then they can be fighting about it because they're the family's just ripped apart. Save your family that burden. Tell, okay, the grandfather clock goes to Sally. My favorite old horse out in, that one's going to go to Ed. And here's the living will. You follow those. Please do that. You know, those kinds of things. And then they don't fight over the horse or the grandfather clock or the feeding tube.
I think it's also important when you're preparing a living will, probably the most important part is the conversation, but then naming the person that's going to speak on your behalf. You don't want to name my kids if you have 16 kids, because in times of grief and crisis, even family members that you feel are very rational, it can come unraveled. And so really choosing the person that you think is going to be able to speak your wishes as opposed to what they want for you. It is really important. And sometimes it's not the obvious choice. It's not always your spouse. It's not always your children. Sometimes it's a really close friend, a neighbor. So choosing that person and putting that down in a legal document and then making sure that they're aware of what's important to you.
But boy, make sure the kids all know that that
Yes.
person's going to be following my wishes. That's their obligation, is not to follow what this guy says, but my wishes are kind of what you guys need to, that's the obligation.
That's right.
And you made a great point earlier, Rick, about where you are in your life, if you're in your 60s versus your 80s. And that's a great reminder that if you have had the conversation with your family and you have created advance directives, but maybe a decade has gone by, or maybe it was before you were diagnosed with a chronic disease, or maybe there's been a divorce. So there's certain triggers in your life that should give rise to revisiting the conversation and making sure that that document is up to date. Because Dr. Arneson and I have worked on cases where the spouses were separated, but the separated spouse was still the decision maker for the estranged spouse. Or there has been a rift in the family and the advance directive was never updated. So technically, legally, this individual then had decision-making authority. And often they didn't want it because they'd been estranged from the patient and they felt like they were in a situation of conflict.
I'm going to put my living will, my advance directive, on our site so that you could look at it and you might want to formulate your advance directive in a similar way. And so I'm just we'll put that on the site. It'll give me a week. Give me a week. Hospice means a lot to those who receive the care and those who give it. And sometimes they can be the same person.
I just think it's one of the best and nicest groups there can be, and they take wonderful care of people. I know, experience, firsthand. My husband, Pete, was so sick. Why, then Dr. Holmes recommended hospice for him. And we kind of drug our feet at first because, you know, we're the type, well, the generation of not all this good stuff, you know. But then Mavis came down, visited with us, and talked about it. And it was either that or go for him to go to a nursing home about that time. So we took hospice, and it was wonderful. And the nurse had come down 3 times a week at least, if needed more, but that was her regular dates to come down. And Pete looked for Debbie, his nurse, to come and see him. If she didn't, he was disappointed. And they're so good with them, with the patients. With all his vitals, and he would have skin eruptions and breakouts, and they would doctor those and take care of it for him, teach me how to do it so I could do it in between time. He was right here at home, and all the kids were here with me, so it worked out real good. I play for a lot of the nursing homes, and wherever hospice needs me, I go play. You know, each client brings a different feeling, and you kind of grow attached to each one of them, whether you're with them real long or not. And I guess when I'm playing for them and they start keeping time to the music with their foot or maybe mouthing the words or something, that's my good feeling, yeah. with the family and everybody agrees on it, why yes, that's the way to go. They're a great bunch.
That is one lovely, beautiful lady with a wonderful heart, just about the sweetest person I know. Thank you for doing that, Nancy. She talked about hospice and that they finally accepted the idea. There's a lot of fear people have about hospice. Does that mean I'm going to die? Franny, how would you take that?
Well, I think that it means that you're facing something really serious, and we're worried about you. The guidelines state that we have to have, with a certain degree of certainty, that we're looking at 6 months or less, prognosis-wise. We're allowed to be wrong, though. Doctors are humans, and sometimes the care that a hospice team provides, especially in chronic illnesses, when I think about that, end-stage heart disease, end-stage lung disease, sometimes having those frequent visits in your home allow you to actually do better, and we end up having to give you the boot. Yeah, kick you off because you're doing too well. And hospice teams celebrate that when
we do. We're kicking her off.
That's right.
Hospice team.
The families sometimes really mourn it, though, because they become so close with those caregivers that it's a real void then. I think that more often than not, and you'd probably agree, being a medical director for years, most families say, why didn't we know about this sooner? The type of care that's provided is really exceptional. And I would say that the hospice teams that I've worked with personally, it's more than a career, it's a calling for those folks, and they feel passionate about it.
Yeah, and those meetings that we have every Tuesday at 1 o'clock in Brookings is like one of the highlights of my week, because these people come with this caring thing. You feel it. It lifts you up. I think that it's an added Medicare benefit. There's money that comes to the family of support and so on and so forth. And if the doctor is willing to say, well, I think you qualify, why not take it? And, sometimes you have to kick them off. I mean, I had a lady with an abdomen full of adenocarcinoma unknown primary. She was in her mid-80s, and we opened her up and closed her up, debulked the tumor, and put her in hospice, and then 6 months later kicked her off of hospice, and she died 10 years later of a heart attack. And I had another one who did the same darn thing. I mean, sometimes you just don't know. You know what I mean?
Yeah, absolutely.
Your response, Mary, to that issue about people being too late to be put in hospice. I mean, I think that's the big problem. The doctor doesn't have the family's reluctant, and so it's the last week.
Yes, absolutely. I think often families don't want to give the impression that they're giving up on their loved one, that they've kind of called it quits, or they're not willing to fight along with them for more curative treatments. I think also that there's a misconception that in hospice that the patient will not be getting the care that they need or deserve. And actually, the hospice philosophy is a very holistic philosophy of care. Hospice addresses physical symptoms, and as importantly, and often more importantly, it addresses psychological symptoms, spiritual suffering, what we call existential suffering, which is facing those questions about who am I, why am I here, did my life have meaning, are my relationships whole, do I have anyone that I need to reconcile with, and not just the patient, but the family. It's a very holistic philosophy of care that embraces the entire family. Pets are part of hospice. I've worked in organizations where the pets lived at the hospice facility, and that's an important part of the patient's care. So a lot of it is the misconception, and then some of it too is, I think, our ethos in our culture right now of we've paid into our Medicare benefits, and we want to get everything that we've paid for. We have all this technology. Certainly something must be able to be done. There's got to be another drug, another treatment, et cetera.
So what is your exact definition of ethos? Explain that just a little bit better.
So the worldview, or what we hold important, how we, some of the foundational assumptions that we come into our situations and have. So I think in America we're about hard work, the work ethic, and that we've made our lives, we've been successful, and now now we're going to reap the benefits of our hard work and what we've done.
The fundamental questions of ethics: who are we, who should we be, and who should we do, what should we do in light of this?
Yes.
That integrity, that identity, that's, so I'm going to throw this at you, Franny. I mean, we had an earlier discussion with pre-med students. I mean, I always loved that part, and to me, the pre-med students, brings us to a certain level of thinking, and then sometimes we think but we talked about that existential suffering. Now I'm going to throw that at you, Franny. Existential suffering, how would you define that, and where is that? You're a young person. Your existential suffering is in a different time frame now than it is for me in the 67th year.
Yeah, I see it very, very similar to how Mary described it, kind of how we see ourselves connected with the world and those around us, how we find meaning as we face our own mortality through life experiences. What does that mean for us? What's the bigger sense of the world? How am I connected? What was the meaning of my life? Those questions that I think that when we're in our teens and our 20s and we feel quite invincible aren't things that we ponder too deeply.
No.
And as we accumulate life experiences and we appreciate how fragile things can be, sometimes we spend more time thinking about that. And I would imagine when we're faced with a terminal diagnosis or something really serious medically for ourselves or a close loved one, we're kind of forced to think through those things. And everyone deals with that differently. And that's one of the things that palliative medicine and hospice tries to tend to.
Right.
We ask those questions. What are your hopes? What are your fears? Given what you're facing, what are you most worried about today? What can we help you with?
So my response to this whole question of existential suffering and the question of the meaning of life and so on, is that many people are still gripped in the panic of the fear of death.
Yes.
And they may be very religious or not religious at all, and there are people who have been able to grip that particular, or face that particular thing, and what is it that brings them to that? And I wrote an essay a couple years ago about how dangerous it is to be fearful of dying, because it puts you in a higher level of risk of severe pain, and that we run from it. And many times when you run with fear, and you're filled with fear, it just makes it worse.
Yes.
Response to that?
That sounds like some of the writings I've read from the Eastern philosophers about that suffering is when you are resisting what is. And so those who have the least suffering are able to accept what is and what shall be without that resistance. And certainly that's what you're describing, Rick, that fear, and then you resist and contract and make choices that might not be in your best interest because you're not thinking with your full rational self, because that fear is really cutting off some of your that frontal lobe activity and the resource that you have from your higher brain.
Yeah. The Abrahamic religions, I think, though, also can, you can interpret in that Eastern way too that asks, that says, it is what it is. I approached a man on his death, and I hugged him. I wept because he was the doctor that I loved, that taught me everything about how to live. I mean, one of my heroes, Dr. G. Robert Bell from De Smet, and I said, I'm so sorry, this is, and he elected to stop the transfusions and just to let go, and it was time. And he said, well, it happens. It is what it is. And I thought, okay, and it is what it is a modern statement, isn't it? Yeah, we hear that now. It's modern, right? Well, I'm reading Black Elk Speaks. Okay, so Black Elk Speaks was, Black Elk was an Indian that lived in the mid-1800s all the way up until, into the 1900s. And he was he was a medicine man that was, that had an opportunity to have an interpreter, and they wrote down everything that he said, and he just gave wisdom after wisdom after wisdom. And on one of the particular chapters of his words of wisdom, he says, it is as it is. Yeah. Our Native American indigenous population had this figured out a long time ago.
I have that book on the bedside table. I haven't started reading it. It was given to me by a lawyer friend, so I know you like to diss lawyers, but that's a little credibility from a lawyer. So you mentioning it is maybe the prompt I need to start reading it.
Read that magnificent book. Read that book.
It's interesting, I think, though, when we talk about existential suffering, I've seen such a large spectrum of end-of-life coping. And I think that everyone walks that journey a little bit differently. I've seen many, many patients with strong faith and not have a great deal of peace at the end of life that baffles me. It's humbling. And then you have all sorts of different fears, actually. It's not always about the unknown and what comes next. It's sometimes a fear of suffering. Maybe they saw their mom die of COPD, and now that's what they're facing, and they're scared of suffocating. Right. Or they're scared of what is their spouse gonna do because they counted on their income. It's oftentimes very selfless things that they fear the most, and I think that until we talk about it and ask them what they're worried about and what their fears are, we don't really know. We can guess, but we don't really know. I think also when you talk about suffering, all of the types of suffering that we can experience outside of physical suffering, I think it's really important that we look at it as a whole person, because we've seen many, many, many patients that we can't get their pain under control. Well, certainly they have physical pain, but that's not what's driving it. And until we address their spiritual concerns or their emotional concerns, or talk about what is going to happen to your 3- and 5-year-old when you die, and give them peace of mind, that we're able to then control the physical symptoms, because as humans, we're not just a list of diagnoses. We're so much more complicated than that.
Let me just say, in other words, what you just said, which I think is just this huge, huge wisdom, and that is, this is the time your family's home with you. Talk to them about death. Talk to them about your own fears. Talk to them about the things that you would like and you wouldn't like. Just have that conversation, and it will free you. And so I'm not talking about fear, and I'm saying release yourself from that. You agree?
Yes.
Yes.
Medicine doesn't always come from pills. It may also be just a gathering of people who care.
Come, come, come. There's a land that is fairer than they.
They did that while he was in the hospital, and he really enjoyed that. Yes, that was a very, very nice thing for them to
do.
Hopeful Spirit Chorale is a group of kind of multi-generational people. We've got a lot of retired folks, a lot of folks who work, and then some college students as well. We meet on Tuesday nights and we practice singing, and then we go and sing to a hospice patient or an elderly patient or someone who just needs a little bit of brightening their spirits.
Oh yes, a lot of personal satisfaction, a lot of camaraderie, not just with the patients, but with everybody that sings, and it's a great group of people, and just there's a lot of age range, from college students to retired people. So I get to meet a lot of nice people and talk with them, and we all get to go and do something nice for someone who's a little down.
Yes, I'm not much of a singer myself, but I've really enjoyed seeing, the difference that we've made, especially for these people's families, because it's a really rough time for them.
Just so pleasant, such a pleasant experience.
It's not so much about the singing either. It's just about, giving up that hour every Tuesday and doing something for somebody else, and they really appreciate it, and I would totally recommend it.
We shall meet on that beautiful shore.
I have to say, it's such a joy to be with that group of people. It is just this, our music may not be exactly perfect, but it is such a wonderful receiving thing to sing. And it's a cappella, it's 4-part harmony. We have all the different churches. It's not church so much as it is hymns that people know. Yes. And it's very, very comforting. So I'm pleased to be part of that. What a joy. There's some things that we should talk about. The biggest bugaboo that I have seen in these advanced directive situation, end-of-life situation, is when families caught in a fight. Yes. Give me talk about that, both of you, please.
Unfortunately, I've seen it more times than I'd like to admit. I think that when families are caught in a crisis and are struck with grief and haven't prepared properly, bigger families, smaller families, it affects all families. There can be large differences of opinion amongst family members as to what mom or dad or whatever loved one is in the crisis would have wanted.
And you know what, I'm going to have to add, some of them don't even think about what they would have wanted. Right. They don't realize their obligation is to do what mom or dad would have wanted, not what they want.
Right, and sometimes they'll even be able to put words to that and say, well, we know dad would never want this, but we just can't bear to lose him. And grief does crazy things to us sometimes and can really affect our judgment. And unfortunately, some of those rifts that are created amongst families in that time of crisis can last years later and really pull families apart when it should be a time to bring families closer together over celebrating the life of their loved one.
Wow. Mary, you want to expound on that? Because that, there is the rub. Like you say, you see it way too much.
You do.
Yes. And I recall an example of a friend of mine who was the medical director of our internal medicine service at a very large teaching hospital. And he shared that when his sister had a terminal diagnosis, and she was a young woman in her 30s with young children, he said, it didn't matter that I was a physician. At that point, I was a grieving family member, and I was irrational. And even though I knew her prognosis was extremely grim, no hope of survival, I was still insisting on all types of technology. So he gave this very powerful testimonial about the importance of having the conversation and choosing a person, as Dr. Arneson mentioned earlier, who will be able to carry out your wishes during extremely stressful circumstances. And oftentimes that will not be a family member. I know many healthcare professionals who've asked colleagues or friends who were also healthcare professionals to be their surrogate. Now, that's not always going to be the answer. Often, if not most of the times, we'll see a family member making decisions. But think about assigning one person as your primary spokesperson and decision maker, because even though it might sound good to have 2 of your children or 2 of your siblings, what you'll often end up with is a disagreement between those individuals. And then that might last, as you said, way beyond the death of the person. Okay. So it's good to talk with your family and identify someone who you think can really stay calm. Yes.
And to make clear to everyone that that spokesperson is representing the wishes of the person.
Yes.
I mean, they say that your ethical responsibilities are to do good and not do harm, to be honest, and to respect the choices of the individual. That autonomy, that choice of the person should be respected. But people will say, oh, well, then I have to go to a lawyer to get this. I mean, is there a, I know there's a thing called 5 wishes, and there's been some argument. I've talked with lawyers about 5 wishes. Too many wishes, it's not, you can't outline what's gonna happen.
Yes.
But you like 5 wishes. Let's hear about it.
I like the beginning part of 5 wishes that talk about what is important to me, what are my goals, what are my values. It's a great conversation guide. So, and I agree with you, you can't have a document that's going to anticipate every eventuality.
So you can find it on the internet?
You can download it on the internet.
But it's under 5 wishes?
You could just Google 5 wishes, and that is a wonderful way to have the conversation and to frame the conversation.
Right.
And then the most important advance directive is for you to assign a healthcare decision maker. And in South Dakota, that's a healthcare power of attorney. Other states have different names for it, healthcare representative. But assign a person to be your spokesperson and make sure that you have the conversation with them and that you keep updating them and staying in relationship with them so that they know if your wishes have evolved or changed.
Okay, so I'm going to give you a situation, and Franny, I want you to answer me what you think would happen.
Okay.
So I've had a big stroke.
Okay.
I'm 67. Let's say I'm 80.
Okay.
Okay. I just
You
had
don't
a
look
big
80.
stroke. No, I don't look 80, but and I am not 80. But thank you. So I had a big stroke. I'm 80, 85, and I come to the emergency room. Family scrambled, and it's 6 hours. Actually, it was a big stroke. They're not going to do the streptokinase or any of the clot busting drugs or TPA or whatever they're going to use. I've got this huge stroke. I have an advance directive. I've picked one of the kids, or I've said all the kids would come to this, and I've talked with them about it. And the advance directive said, if I have a cardiac arrest, let me go. Mm-hmm. If I have a chance, just like I said earlier, if I don't have a really great chance of recovery, no feeding tube. So they all are there, and it's the emergency room, and the family says, oh my God, we're lost without him, and we just, we can't bear to do it. We want the feeding tube. And the doctor is looking at me, even has a copy of the living will, and is hearing the family, and the family says, do it. And she or he looks at me and thinks, this guy's not going to ever sue me. They could. So that doctor in the emergency room is going to do what, do you think, Franny?
Well, it's not as simple as that.
Okay.
In the emergency room, we probably wouldn't have to place a feeding tube in that moment. And my hope would be that the medical team over the next several hours to days would have more in-depth conversations with that family to try to wrap our head around what are they feeling, what are they experiencing. Tell me about conversations that you've had with Dad in the past. When did he fill out this advance directive? What prompted him to do so? Was it the death of a close loved one? And talk about that experience. Get to know them as a family. Learn more about him and his values as a person, as a human. And try to get to the root of what the fear is about letting Dad go and respecting his wishes. I think that oftentimes in medicine, there's a misperception that we have to jump to an intervention when sometimes we can give it a little bit of time.
Right. And that's the essay you'll hear a little bit later. But that doctor will commonly follow the patient's family's directive and not the living will, right, Mary?
Often that will happen, but again, a living will is only effective if it's been determined that the person has a terminal condition from which they're likely to die from very shortly, or they have a permanent coma or
It's
persistent.
hard to know that right away.
You won't know that right away. Now here's the other point about those interventions that happen because families are panicking or grieving. We often will do time-limited trials. So we'll start an intervention, but if it shows over the course of days or a week or two that it is offering the patient no a meaningful benefit. So yeah, maybe it's prolonging their physiologic existence, but they're continuing to decline and their death is imminent. Oftentimes the family by that point can come to it.
I would give you this answer though, in my own mind. The way I handle those big strokes, because this is what happens. They get edema up there. There's a lot of swelling because of what's going on. My answer to the family is, let's let them dry out. Let's let the edema come down a little bit. We don't have to start anything right now. We have some days. By day 3, they're generally going, oh God. And I mean, oh God, this is what we're facing. And they're willing to not start the feeding tube, not start the IV fluids. And it's helped me in the years, because what happens is if you don't give them water or food or anything, they'll have a comfortable end in about 10 days. Sir William Osler wrote about it in 1904 and how people gently died. And there was a wonderful essay where they contrasted the support study that I talked about in 1998 with Sir William Osler's, and went, what are we doing? We were better with Osler at the end of life. So just that, you know, IV fluids have been a true blessing and a challenge for us.
Yes, and you're going to tell us about that answer to the question that was in the beginning of the show about whether the tube feeding actually reduces the risk of aspiration or other complications. So we're waiting with bated breath.
We are.
Yes.
Well, then we're going to do that. And now for the answer of tonight's Prairie Doc quiz question: it's a true or false? Placement of a feeding tube improves survival by reducing the risk of aspiration or food going into the airway. True or false? And the answer is false. Give me your response to that.
I think that in certain situations, feeding tubes can be very beneficial, and it's a technology that I'm grateful that we have. It's, again, a physician and medical team.
And we have 1 minute.
Trying to decide which is the right patient population.
Yes.
Generally, in end-stage dementias, it causes more harm than good. Oftentimes, in other neurological illnesses, it causes more harm than good.
We call it the pneumonia tube.
That's right.
Any further comments, Mary, on that?
I would defer to my 2 medical experts, and I would also say on the advance directive, you don't need an attorney to complete that. You had mentioned that earlier. In South Dakota, that is not required, so don't put off having an advance directive because you don't want to deal with an attorney.
Do you have a place that you would recommend people go? No.
Yes.
Oh, what?
They can call their health provider, call their local hospital. Churches will often have parish nurses and forms.
Very good.
And you don't have to pay for it. It's free. You can download forms online, and all you need is it to be notarized or witnessed by 2 individuals, and it's
read
legal.
it out loud to your family.
Yes.
We'll be right back after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too. And some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule, so he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
The elderly late 80s gentleman came into the emergency room unconscious with the diagnosis of new stroke. A CT of the head indicated that there was no bleeding into the brain or around the brain, so he had a blood clot, not a bleed, that caused the acute brain injury. The symptoms began 6 hours earlier, and the patient and his family just didn't get him to the emergency room in time to try a clot-busting medication that can sometimes save the brain. The family and I had a long talk. The patient had been living alone in his home of 50 years, still daily visiting a nursing home to see his wife who had severe Alzheimer's disease. He had an advance directive about which his family was aware. He had enjoyed a good life, his financial affairs were in order, he didn't want resuscitation if this was required, and I remember his words, "That would be an easy way to go, so do not resuscitate. And whatever happens, no feeding tubes unless I have a reasonable chance of returning to a normal life where I'd know what's going on." Our patient had significant brain injury with no capacity to swallow or speak and minimal awareness. With family's agreement, we did not start intravenous fluids in consideration for brain edema or swelling that can occur in new strokes, and gave it a little time to allow for the edema to reduce and perhaps improve the situation. This also bought some time to see if we were going to get any recovery or not. After the third day, the writing was on the wall, and his chances, if he survived, would require a feeding tube. The family directed me to follow his advance directive and allow a natural death. Over the next 9 days, he gently slipped away, no feeding tube, no respirator, no suffering. Take-home message, number one, make an advance directive and use it as a communication tool to talk about end-of-life choices with your family. Number two, realize that the patient's choice is primary. If the patient is not capable, the family chooses for the patient, and their obligation is to respect the patient's prior expressed wishes or do their best in how he would have chosen. And sometimes this may mean pushing against what the care providers are wanting to do. 3, because of no advance directive and because families don't realize their responsibility to respect the dying patient's wishes, too often feeding tubes are placed, and what might have been death with dignity becomes one with suffering. A great big thank you to our guests, Franny and Mary. Thank you both so much. Their experience brought great insight to our topic tonight. Say, the flu is here, folks. Don't delay. Get your flu vaccine now. Reduce your chances of catching the flu bug this season. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions, Brookings Health System, Ophthalmology Limited, South Dakota State Medical Association, Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision, Aberdeen Asthma and Allergy, Black Hills Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, Regional Health, and Swiftel Communications.